Good morning, Chairman Emeritus Sir, Vice Chancellor Sir, Pro Vice Chancellor Sir, my seniors, my colleagues, and my juniors and students. Good morning to you all. I'll be briefing about my department of gastroenterology, medical gastroenterology, that was founded in the year 2015. It is a well-equipped department with all facilities for learning and hands-on training of endoscopy. And we have renowned faculties who are proactive in teaching and interactive learning. We have 3 full-time professors, 1 assistant professor, and we have 5 classes a week, that is from Monday till Friday. Myself, I had been in SMS for 35 years. I am the member of editorial board of Digestive Endoscopy. It's a national journal. And myself, I have indigenized 25 endoscopic accessories when the time it was there when poor patients could not get those accessories for their management. I have edited 3 books of all 3 subjects, that is gastroenterology, hepatology and endoscopy, and contributed 5 chapters in various books. I have done around 175 publications in various national and international journals and received 10 awards for contribution in gastroenterology and endoscopy. These are all academic awards only. I have Dr. Rajat Bhargav, Dr. Akash Rajendra, both are professors, and Dr. Sumit Yadav, assistant professor. All 3 have one motto, that is patient management, and they are eager to treat patients. Patients should get better, that is their motto. The DM in gastroenterology started in the year 2016. Initially, there was 1 seat per year, and it was increased to 3 seats in 2020. Up till now, 7 students have passed. We have fellowship program also in GI endoscopy. We have state-of-the-art endoscopy lab and an ERCP lab. The ERCP lab is as good as any operation theatre. We have student-centric learning. We have collection of presentations, video lectures by senior professors and eminent faculty members. We have interdisciplinary lectures also, and we have even guest lectures from prominent national and international faculties. And endoscopy laboratory is well equipped for experimental learning and hands-on training. As far as research and publications are concerned, myself I have 175, Dr. Rajat Bhargav has 40, 36, Dr. Akash Rajendra, and Sumit Yadav has 10. These are the various recent publications which have been done from the department. We have departmental library, air-conditioned seminar room, endoscopy lab, e-library, ERCP lab. Our ERCP program, actually we don't do diagnostic, these are all therapeutic, and it has a positive graph. From 2022 it was 640, it rose to 684, and now we have done in the last year 720. Upper GI, lower GI endoscopy, modern endoscopy suites are there with all equipments. We do all sort of therapeutic works like ligation, sclerotherapy, stricture dilatation, glue injection, foreign body removal, and various other procedures. Endoscopic procedures 4,876, 2022 rose to 5,378. The OPD data also is on the increasing trend. Last year we had 15,890, almost 16,000 patients in the OPD, and also there is an increasing trend in the IPD. Last year we are actually reaching around 1,500. So our future plan is endoscopic ultrasound, which will be starting in this week only. We have already procured the instrument. We had a workshop last week. Capsule endoscopy in this month we are going to start it. Manometry soon in a month or so. We are ordering for the manometry also, and hydrogen breath test also. So all these four will be added in this year, and by Chairman sir, we have an upcoming Center for Digestive Diseases by the end of this year. That will be with all GI specialties and allied specialties under one roof. So I had been in medical college for 35 years, and now here I am for 3 months, and there's a drastic difference between the services which were there in government and here, and I'm very happy to say that here the management of the patients and even the teaching programs are better than any government institute. Thank you very much. Now I'll actually invite my residents to carry the further proceedings.
Good morning, respected teachers, my seniors and colleagues. Today's CCR is on a young male with recurrent pain abdomen. He is a 28-year-old male, student, unmarried, resident of Karoli, Rajasthan, having low socioeconomic class according to modified Kupuswamy scale. He presented to us with chief complaint of recurrent pain in upper abdomen for 1.5 years. He had pain for 1.5 years in mid-upper abdomen, which was insidious in onset, on and off. Initially, the patient had 1 to 2 episodes per month, which were lasting for about 1 to 2 hours and have increased to 4 to 5 episodes per month of duration of 2 to 3 hours in the last 5 to 6 months. Pain was limiting his daily activities and also was occurring during sleep. It was boring, of variable intensity and radiating to back. Pain was aggravated by fatty food and relieved on bending forwards and taking medications. Earlier, the patient used to be relieved on oral analgesics, but now he requires IV parenteral analgesics in the last 5 to 6 months. Sometimes the pain was associated with vomiting and nausea, and vomiting contained partially digested food. Pain was aggravated by eating, which led to fear of eating with insignificant weight loss. Earlier, the patient used to take 2000 kilocalorie per day, which now has reduced to 1500 kilocalorie. He was treated conservatively as inpatient multiple times. There is no history of retrosternal burning sensation, fever, jaundice, polyuria, polyphagia, polydipsia, foul smelling and greasy stools, diarrhea, bloating and constipation, abdominal lump, hematemesis or melena, hematuria or dark colored urine, no past trauma. There are no major surgical illness reported, no history of diabetes, hypertension, asthma or TB. In drug history, there is history of taking analgesics at the time of pain. Earlier, patient used to take tablet diclofenac. Now he requires IV tramadol. There is also history of taking pancreatic enzymes for 2 months, and there is no drug allergy reported. In personal history, he is a vegetarian, non-alcoholic, non-smoker, having normal bowel and bladder habits, and no significant family history. Summary: he is a 28-year-old male with complaints of recurrent pain in mid-upper abdomen for 1.5 years, boring nature, on and off with increase in intensity and frequency from last 5 to 6 months and radiating to back. Its pain is associated with nausea and vomiting, relieved on bending forward and medications, and it is adversely affecting his studies. Now I would like to ask the audience, what do you think are the possibilities after history? Sir, it is a dull aching continuous pain in a particular quadrant, sir. Sir, usually, sir, the pain is divided into nociceptive and type, and sir, neuropathic type, sir. In nociceptic, sir, it is divided into somatic and sir, visceral. Sir, it is a part of visceral pain, sir. Yes, sir, sir. In Schlesinger, sir, it is written, sir.
Boring here means that the pain is as if it is boring into the back. It is
Yes.
not that the patient is getting bored of pain.
Yes.
Boring.
Yes, sir. Yes. Yes. So I would like to request the audience, what do you think are the possibilities on the basis of history? Yes, thank you. Any other? Yes, thank you. So after history, the more likely possibilities in this patient are pancreatitis, which may be chronic or recurrent acute pancreatitis, or peptic ulcer disease, or biliary lithiasis. The less likely causes can be chronic mesenteric ischemia or metabolic causes like porphyria. In general physical examination, patient was examined in a well-lit room with proper verbal consent. He was conscious, well-oriented to time, place and person. Patient was averagely built and averagely nourished with a BMI of 21 kg per meter square. Pallor, icterus, clubbing, cyanosis, lymphadenopathy and edema were absent. Vitals at presentation were pulse 84 beats per minute, BP 122 by 82 mmHg in the right arm supine position, temperature 98.5 for Fahrenheit and SpO2 98% on room air. In the abdominal examination of the patient was inspected in supine position with leg flexed, arms on the side and exposed from nipple above to mid-thigh below. Abdomen was flat with central inverted umbilicus. All the quadrants moved equally on respiration. There were normal respiratory movements, that is abdominothoracic in male, no scar marks, dilated veins, pulsation and visible peristalsis. There were no swelling seen over the abdomen. Hernial orifices were normal and external genitalia was normal. In palpation, local temperature was normal. Abdomen was soft. There was tenderness present in epigastric region. Guarding and rigidity were absent. There was no lump palpable. Liver and spleen not palpable. Both kidneys were not palpable. All hernial orifices were normal, and there was no abnormal findings on rectal examination. In percussion, there was tympanic note all over the abdomen, and on auscultation, there was no bruit and normal bowel sounds. Other system examination. In respiratory system, air entry was bilaterally equal and no added sounds were present. In CVS, S1, S2 was heard, no abnormal sounds were added. In CNS, patient was conscious, oriented to time, place and person. Now, after the clinical examination and history, again I would like to ask the audience, what do you think can be the diagnosis DDs in this patient? After history and examination, the possible DDs are more likely pancreatitis, then peptic ulcer disease and biliary lithiasis. Now I would like to request Dr. Shoolpani Mishra to discuss the investigations and take the case forward. Thank you.
Thank you, Dr. Vikram. Good morning, everyone. So with these differential diagnoses in mind, we proceeded to investigate the patient further with routine blood investigation. Hemoglobin was 12.9 gram per deciliter. Total leukocyte count was 7,800. Platelets slightly on the lower side with 1,23,000. Liver function test, renal function test and electrolytes were normal. Viral markers found to be negative. Serum lipase level and serum triglyceride level were slightly on the higher side, with HbA1c, random blood sugar and serum calcium levels were normal. Stool for fat globules found to be negative. We did the X-ray abdomen erect for this patient, and there were no radio opaque shadows seen on the mid upper abdomen, and prominent bowel loops are present. Ultrasonography abdomen suggestive of pancreatic head, mildly bulky with heterogeneous ecotexture of the head and visualized body. Few hyperechoic foci is seen in the pancreatic parenchyma. Main pancreatic duct is dilated, measuring around 10 mm. Features are suggestive of chronic pancreatitis. After these features, following that, we requested to do the MRI and MRCP of abdomen. To discuss the MRI findings, I would like to invite Dr. Gargi Singh of the Department of Radiodiagnosis.
Good morning, everyone. I am Dr. Gargi Singh from Department of Radiodiagnosis. I will be presenting the MRI findings of a 28-year-old male who came with chief complaint of abdominal pain radiating to back in the gastroenterology department under the guidance of Dr. Mishra sir. Here we have T2 weighted axial sections. In this, the normal pancreas appears hypointense on T2 weighted sequence with a thin hyperintense line representing the main pancreatic duct. It is of normal thickness, but in our case, the main pancreatic duct was dilated and tortuous, measuring approximately 6 mm in diameter, with prominent side branches and relative thinning of pancreatic parenchyma in the tail region. In this T2 weighted axial section, the pancreatic parenchyma of body region appears relatively thinned out with dilated pancreatic duct. Few focal hypointensities were seen in the head region, representing parenchymal calcification. In this T2 weighted axial section, The lower part of head region appears bulky, edematous and hyperintense with peripancreatic fat stranding and nodularity, suggestive of acute pancreatitis. The MRCP images revealed that there was no obvious calculus in gallbladder or the common bile duct. The main pancreatic duct was dilated and tortuous, whereas it was difficult to visualize it in the head region. So we have again evaluated the proximal main pancreatic duct on T2 weighted axial sections. Two hypointensities were seen in the expected course of the proximal main pancreatic duct, which was narrowed or effaced in the head region, likely due to recent pancreatitis or a stricture. One of the hypointensity was better appreciated in the coronal section, measuring approximately 4 mm. These could be parenchymal calcification or the calculi. So the key findings were dilated and tortuous main pancreatic duct with prominent side branches, relatively parenchymal thinning in body and tail region with parenchymal calcification suggestive of chronic pancreatitis, bulky and edematous lower part of head region with peripancreatic fat stranding suggestive of acute pancreatitis. The proximal main pancreatic duct was narrowed or effaced in the head region, likely due to a stricture or recent pancreatitis. There was suspected calculi or parenchymal calcification in close proximity to the proximal main pancreatic duct. So a diagnosis of chronic pancreatitis was made. Now I would like to invite Dr. Shoolpani sir.
Thank you, Dr. Gargi. So here now question arises, what are the causes of chronic pancreatitis? TIGARO A is an acronym by which we can categorize the different etiologies of pancreatitis. Number one is toxic and metabolic causes, idiopathic, genetic, autoimmune, recurrent and severe acute pancreatitis, obstructive and mechanical causes. In case of our patient, he is a non-alcoholic and non-tobacco user. Serum calcium levels were also normal. Serum triglyceride levels are slightly elevated, which doesn't going to cause pancreatitis. No features of chronic renal failure are there. No features suggestive of autoimmune, recurrent and severe acute pancreatitis, obstructive and mechanical causes. So now we are left with the idiopathic and genetic causes. We are planning to do the genetic workup in near future and for the follow-up. So now we are left with the idiopathic. On the basis of clinical and radiological findings, we reach to our diagnosis of chronic pancreatitis, query idiopathic without associated exocrine and endocrine insufficiency. To further handle the management part, I would like to invite Dr. Salman to discuss.
Following are the issues in the management of chronic pancreatitis, pain being the most common issue and is seen in more than 90% of the patients. Other issues may be pancreatic insufficiency, ductal disruption leading to pseudocyst, ascites or pleural effusion, bowel obstruction, pseudoaneurysms, portal vein and splenic vein thrombosis, biliary obstruction and pancreatic cancer. In our patient, the issue was pain management. Mechanism of pain in chronic pancreatitis. Pain can occur due to intraductal hypertension, interstitial hypertension, pancreatic ischemia, and neural remodeling. Pancreatic duct stricture, stones, fibrosis and inflammation may be implicated in these mechanisms. Pseudocyst and extrapancreatic causes may also be the cause of pain in chronic pancreatitis, but these are not present in our patient. Management options include medical, endoscopic and surgical. In medical management, we may use analgesics, antioxidants and pancreatic enzyme replacement therapy. Our patient was already taking pain medications and pancreatic enzyme replacement therapy for more than 2 months, but there was no relief. So patient was discussed with surgical gastroenterology team and decision was taken to go ahead with endoscopic therapy. These are the features favoring endotherapy or surgery. If fewer stones and stones confined to the head and body of the pancreas and stone diameter less than 10 mm with absence of impacted stones. As our patient had all the above favorable features, he was deemed suitable for endotherapy. In endoscopic therapy, the options are pancreatic duct drainage by sphincterotomy or stenting, pancreatic duct stones removal by endoscopy or extracorporeal shock wave lithotripsy, pancreatic duct stricture dilatation, and relief of pancreatic pain by EUS guided sealess plexus block. The aim of endoscopy was ductal decompression to reduce intraductal hypertension, intraparenchymal hypertension, and pancreatic ischemia, thereby reducing the pain. In endoscopic therapy in our patient, first sedation was administered and then side wing endoscopy was done. Side wing endoscope is a specialized endoscope in which the working channel, camera, and light source is located on the lateral surface of the front of the endoscope instead of being in the front to allow better visualization and working on the duodenal wall. First, the endoscope was inserted through mouth, then into esophagus, and advanced into the stomach. After that, the endoscope was advanced into duodenum, where major papilla was identified. Major papilla is the common opening of common bile duct and pancreatic duct, and it opens into the second part of duodenum. Here we can see after that a selective cannulation of the pancreatic duct was performed with the aid of a guide wire. In this diagram we can see a guide wire. This is the endoscopic view of cannulation of the main pancreatic duct, which was performed with the aid of fluoroscopy and guide wire. After that, radio-opaque contrast dye was injected into the duct and fluoroscopy was used to visualize the ductal anatomy. The pancreatogram showed partial narrowing at the head and body junction with upstream dilatation of around 10 mm and two small filling defects suggestive of calculi of around 5 mm size.
Is the same patient?
Yes, sir, same patient, sir. I am showing through pointer. So this is the pancreatogram of our patient. Here we can see a partial narrowing at head and body junction with two filling defects. First one is here and second one is here, and there is upstream dilatation of the main pancreatic duct. After that, an incision was made in the sphincter of Oddi using an electrocautery sphincterotome to enlarge the ductal opening, facilitating the stone removal and drainage. This is the diagrammatic video of sphincterotomy. An sphincterotome is a triple lumen catheter where one lumen is for cutting wire, one lumen is for the guide wire, and another lumen is for contrast injection. This is the endoscopic video of sphincterotomy in our patient. Here we can see that the cutting wire is being used to enlarge the papilla, to enlarge the ductal opening, to facilitate the stone removal and drainage. After that, basket and balloon sweeps were used to capture and remove the stone. Here in this diagram, we can see a balloon catheter is advanced into the pancreatic duct beyond the stone and then inflated and pulled backwards, thereby removing the stone. This is the fluoroscopy video in our patient. Here we can see that the balloon is being pulled out along with the stone.
On the audience, this is a reverse image. Not ideal.
Yes, sir.
It's a reverse image.
Yes, sir. It's a reverse. After that, additional contrast was injected into the main pancreatic duct to confirm the removal of this stone. In this pancreatogram, we can see that partial clearance of the MPD was achieved. We were able to clear one stone, and one stone was already remaining in the main pancreatic duct. After that, a plastic stent was placed in the common bile in the main pancreatic duct to maintain the ductal patency. This is the endoscopic video of insertion of a plastic stent over the guide wire in our patient. After the insertion of the plastic stent, it was confirmed on fluoroscopy image. Here in this image we can see a successful placement of a plastic stent into the main pancreatic duct. After that, the endoscope was withdrawn. After the procedure, patient had significant improvement in pain and second session of ERCP was planned after a month and done. The goals of second session of ERCP were to achieve complete MPD clearance and to sequentially dilate the partial MPD stricture which was present at head and body junction. In the second session of ERCP, all the stones were removed. Here in this video we can see that the remaining stone has been removed. It was confirmed on fluoroscopy. The pancreatogram here shows no filling defect with partial stricture at head and body junction and a upstream dilatation of the main pancreatic duct. In the second session of ERCP, complete pancreatic duct clearance was achieved and two plastic stents were placed to sequentially dilate the stricture. This is the endoscopic video of placement of two plastic stents into the main pancreatic duct. First stent is being placed through papilla into the main pancreatic duct. Now second stent is being placed. The same was confirmed on fluoroscopy image. In this image we can see two plastic stents placed into the main pancreatic duct. The result of the ERCP was the patient is now completely free without any analgesics and has joined back his studies and is preparing for civil services examination. The future plan in our patient is stent exchange every 3 months till 1 year. If there is stent dysfunction early, then we will go with stent exchange even before 3 months. If the stricture persists after 1 year, we will consider fully covered self-expandable metallic stents and surgical options. These are the other modalities which can be used to remove pancreatic duct stones. In extracorporeal shockwave lithotripsy, it fragments large and impacted stones. High energy shock waves around 2000 to 4000 per session are delivered and it requires multiple sessions. It is used when the stones are large and more than 5 mm. It fragments stones to less than 3 mm and then stones may pass spontaneously or they may need endoscopic removal. Considering the increasing number of chronic pancreatitis patients being referred to our department, we also plan to initiate ESWL at our center to further enhance non-invasive treatment options for chronic pancreatitis.
Is it the same which is used for renal stones?
Sir, it is slightly different. We have a different software in it. So if we use that machine, then the stones may not be pulverized that effectively. By
Hardware must be the same.
sir, hardware is same, sir.
The character of the stones are different. They are harder than the.
Gandhi machines are normally used for this. And I think one other thing is that they have an ultrasound focusing system in addition to a fluoroscopy focusing system to identify
Yes, sir.
stones. Many of these calculi actually I don't know what this one was, but they can be radiolucent and may not be visualized by fluoroscopy.
Yeah, in our case also they were radiolucent actually. But only I think 5 to 10% stones in the setting of chronic pancreatitis are radiolucent. Otherwise you find.
Stones go through a radiolucent phase, then they get
Yeah.
calcified and they harden. It depends on what stage of presentation you identify them. Later stages they will be heavily calcified and completely blocking the duct.
Yeah.
Smaller stones are more likely to be radiolucent.
Yeah, but in clinical practice, most of the patients they come late, and this is lucky that we have a patient which came earlier, so he got better with the treatment.
Other option is endoscopic intraductal lithotripsy, which uses electrohydraulic or laser lithotripsy for stone fragmentation. It allows direct visualization of intraductal stones and it is effective for hard and impacted and radiolucent stones. Now for summarizing the case, I would like to call upon Dr. Akash Rajendra sir.
Thank you, Dr. Salman. Very good morning, respected teachers, seniors, and my dear friends. Here we have presented a case of a 28-year-old young boy presenting with recurrent pain abdomen, which was severe. He was subsequently diagnosed with chronic pancreatitis and was treated with pancreatic endotherapy with successful results. Pancreatic endotherapy is challenging as it requires good amount of expertise and is limited to few centers in the country. We have been treating pancreatic ductal ruptures in form of pancreatic ascites, refractory pleural effusions, pseudocysts also. This patient was an endoscopic challenge in view of a partial PD stricture and the stones distal to this stricture. Pancreatic endotherapy, a 9.5-year follow-up, 90% of the patient showed stricture resolution, whereas 78% of the patient showed pain relief. In a long-term pain relief was also reported in nearly 70% of the patient when a meta-analysis of 9 studies were done in 536 patients. In another meta-analysis of 16 studies, 588 patients, pancreatic endotherapy delayed disease progression and reduced the need for surgery in early stage chronic pancreatitis. Hence, pancreatic endotherapy is a time-tested modality with a robust literature to support it. I would take this opportunity from Department of Medical Gastroenterology to extend my heartfelt gratitude to respected Dr. M.L. Swankar sir, the management of Mahatma Gandhi University of Medical Sciences and Technology for the guidance and the vision, the Department of Surgical Gastroenterology for open discussions that they helped us in, from Department of Radiodiagnosis for their unwavering support, from CCR review committee for their expert opinions that helped us refine our presentation, and the patient and the family members who had unwavering faith and belief on us. Thank you, sir.